Hello, and welcome to today's webinar, Health Benefits Administration and Care Delivery, Improving Metabolic Health in a GLP-1 World, sponsored by Judy Health and Capital RX. I have a few housekeeping notes before we begin. If you have any questions or technical concerns, please use the Q&A module on your screen. You can resize and minimize the different modules on your screen by using the options in the top right corner of each module. Attendees will receive the recording of today's event. Look for that email within 24 hours. We encourage you to put your questions in the Q&A module throughout the event for our speakers to address, while general comments go in the attendee chat. There will be a time at the end of the presentation for our speakers to answer questions, but you may also receive a response via email after the presentation. You can also use the reaction module in the menu at the bottom to relay items you may like or want to express an emotion to. And now, I will pass the stage to Bonnie Hui-Callahan at Judy Health. Bonnie?
Thank you so much, Cooper, and thank you to the HR executive team for your collaboration on these wonderful webinars. My name is Bonnie Hui-Callahan, Senior Director of Clinical Programs here at Judy Health, and I am so thrilled and so honored to serve as your moderator for today's session. So today we're going to cover what we're seeing in the market from a GLP-1 trend and spend perspective, everybody's favorite topic, as well as dive into some of the great results we've been seeing through our partnership program with Vida called RX Activate. Our speakers today are Sara Izadi and Dr. Richard Frank, and I've had the pleasure of working with both. First of all, with Sara on a daily basis, her clinical enterprise team that she runs and operates at Judy Health since I've been here for the past 5 years. But if you think that's long, Sara has been here for almost 8 years. And also with Dr. Frank, I've had the pleasure of working with him and his team at Vida since our partnership began over 3 years ago. So without further ado, I'm happy to turn it over to first you, Sara, for an introduction, and then over to Dr. Frank. Sara?
Thank you so much, Bonnie, and thanks to the HR executive team for having us today. Thrilled to be here. As Bonnie mentioned, I'm Sara Izadi, Chief Clinical Officer at Judy Health. I've had the privilege to be in the payer space for the last decade and a half, as Bonnie said, 8 years at Judy Health, where I oversee both our benefit and clinical organizations. And our clinical organizations really spans anything from managing formulary, which is a drug list of covered medications, to clinical programs, some of which we build in-house from the ground up, and others through partnerships, such as the one we have with Vida. So with that, I'm happy to turn it over to Dr. Richard Frank, and who I've had the pleasure of working with for the last several years.
Thank you, Sara, and thank you, Bonnie, for having me here today. I'm thrilled to be a part of our discussion. I'm Richard Frank. I'm the Chief Medical Officer of Vida Health. I've been with the company over 4 years now, responsible for its clinical strategy. I appreciate, Sara, you've been managing populations and working in this payer space for 8 years, but I'm up to 20 now, so a bit more. I've been working with populations in a variety of settings, a number of point solutions, Medicare, Medicaid, and Medicare Advantage. It's really a pleasure to be here, and I look forward to the conversation.
Thank you, Frank. Now, Sara, turning it over to you to give us an intro on Judy Health, and then to Richard for Vida Health.
Sure, just framing up who we are and our role in the industry here at Judy Health. So we have been leading the charge as a transparent pharmacy benefit manager since 2018. And our PBM membership spans across the commercial side, employers, municipalities, health systems, really the lifeline and heart of our organization. Here we're talking about cardiometabolic health is Judy. Judy is our enterprise platform that powers both our PBM and our PBA lives. And as you'll see on this slide, we really touch millions of members across the country. Judy is really also the power and the lifeline behind our award-winning customer care team. Judy allows us to adjudicate medical claims, pharmacy claims, and our care navigation platform. Our goal is to ensure that we have the best service, which you'll see here with an client NPS of 86 that has held steady through continuous growth. Judy is also the engine that allows us to deliver care and have partnerships such as that of Vida. Dr. Frank, would you like to tell us a little bit more about Vida?
I would love to. So Vida's been in the population health space since 2014, working with individuals with what we call cardiometabolic disease. Really, it's cardiodiabetes, or also referred to as cardiovascular kidney metabolic syndrome. We serve employers, we serve payers, and really, ultimately, we're serving patients. We are a physician-led, virtual value-based specialty clinic that treats obesity and, as I said, cardiovascular kidney metabolic syndrome with behavior change and pharmacotherapy. We use multidisciplinary teams focusing on really the drivers of cardiometabolic disease, genetics, behavior, mental health, and environment. We work with employers within their existing benefit structure. So typically it's the employer or the payer who contracts with us, and then we serve their beneficiary. We have a number of articles in the peer-reviewed space, and we're currently managing over 4.5 million lives.
Awesome. Thank you, Richard. And now we're going to transition to our first poll question. Just for the audience awareness, we have a couple of these poll questions sprinkled in throughout today's presentation, just to get your feedback, your general thoughts about the topics for today. So the first one is, what are you watching most closely around GLP-1s and cardiometabolic care for health plan members? So we'll give it about 30 seconds or so and go ahead and submit your questions, and we'll see what your responses are. And as we wrap up the first poll question, I will mention the term cardiodiabetes, and Richard just mentioned it. This is a term that's been around for a while, but I feel like has made a resurgence in popularity over the last few years. And I think part of that is because it is such a key driver in driving the prevalence of GLP-1 utilization and cost. And as these responses come in, and we're kind of scrolling through here, let's see. So yes, high prevalence of disease and cost, as I was just mentioning, seems to be one of the topics of interest, but really all of the above, which, not surprising, right? There's so many different factors that go into why we're seeing such a surge in, and continue to see a surge in the GLP-1 utilization rates, as well as the cost of care. So it looks like all of the above is the most popular response here. So I take this as, Sara and Richard, you guys kind of have full reign on what you want to talk about from your opinion. So we'll start with you, Sara. Can you describe what you've been seeing as far as these drivers that are contributing to the rising spend and utilization of GLP-1s?
So let me address the high prevalence and costs first, right? So we are definitely seeing increased use. If you look at the addressable market for just the FDA labeled indications, what is approved today? We're not talking about expanded indication. We're not talking about some newer robust agents in the pipeline. The addressable population is about 40% of the US population. I think what's really critical here is to look at the nuances. And so I recently read a study from KFF that says 1 in 8 US adults have tried a GLP-1 agent. Now, my mind immediately goes, expanded indications, dual acting agents, orals, is that going to expand? But what I remind myself that I need to think about is managing these patients. I think one key concern that we see in incumbent data constantly, and that's been proven by literature, is discontinuation rate, right? And so when looking at these agents and where employers are spending their money, it's important to arm these patients with the right tools to stay on these drugs, to address adherence. When we look at diabetes GLP-1s, discontinuation rates and data that we've seen as well as in literature could be up to 30%. When we look at weight loss ones, up to 50%. And not only that, but what is concerning is that for patients who come off of therapy, they regain about 60% of their weight. So what I like to concentrate on is how do we arm both employers as well as patients with the right tools to ensure that utilization is appropriate in a world where we have emerging indications that I'm sure Dr. Frank will touch on, as well as a robust pipeline.
Yeah, I think you're right, Sarah. Employers are just getting slammed with the utilization and cost of these drugs. I mean, on the slide, you see that an individual with either a diagnosis of obesity or diabetes is spending roughly $21,000 on average for an employee. If they have both diagnoses, it can be as high as $40,000 to $50,000. The drugs themselves, even as the prices come down, continues to be burdensome for employers, and the utilization literally is going through the roof. I think the key about managing this utilization isn't a prior authorization per se, although that clearly helps, but I think there needs to be a clinical overlay. So some patients will be able to achieve significant weight reduction and improvements in their cardiovascular risk profile with behavior change alone. It's not many, and they need the right supports, registered dietitians, behavioral health, coaching, content, tracking, etc. But some patients will be successful with behavior change. Other patients really have a very clear indication for a GLP-1, whether it's Wegovy, Zepbound, orforglipron, the new drug that was just approved last week. All of these drugs really have a place in the pharmacotherapy armamentarium. But when patients go on them, some patients might be non-responders. Some patients can struggle with side effects and not take the drugs the way they're designed. And then to your point, there's a large population of patients who self-discontinue these agents and lose all of their cardiovascular benefit within 18 to 24 months. So this is a complicated milieu when managing patients who have obesity, cardiometabolic syndrome, and are seeking to use powerful drugs. And I think the advantage of our partnership is that we can really deploy a meaningful solution for employers so that they're getting the greatest value out of their investment, which I think is ultimately their goal.
Absolutely. And Richard, I'm excited to, as we progress through these slides here, get into how Vida helps with managing and kind of controlling the appropriate utilization of GLP-1s. And before we get into that, speaking of drug spend, let's take a quick step back here. And Sara, I'm going to have you quickly touch on this. Can you walk us through what the quote unquote formula is when it comes to comparing PBMs in the procurement process? What has historically been heavily weighted in the industry and what has been historically underweighted? And why is that important to highlight?
Sure, thanks, Bonnie. So I'm just going to quickly touch on this, as you said, from a pharmacy cost perspective. When plan sponsors or consultants are evaluating PBMs, there's this thing called a spreadsheet analysis. And what we've seen historically is unit cost has been highlighted. And really what drives unit costs are administrative fees, dispensing fees, but primarily rebates. And for every dollar of rebate received, historically, we've seen $2.50 of drug spend. Now, with more emphasis on transparency, with some would say rebates are going away, which I would disagree with. They're not fully going away. But with really more emphasis on transparency, rebate values, what we've seen is more of an emphasis on drug mix and management, which has been historically underweighted, but it's now coming to light. So what this is really formulary development, again, benefit election, whether one covers GLP-1s for weight loss or not, what drugs are preferred in the management of these, right? So that be utilization management edits, such as prior authorization, quantity limits, drug utilization reviews, or programs, high-touch clinical programs that are member-centric and tailored to the member's needs, like Dr. Frank said. So we're seeing an emphasis on this to really control drug spend, and it's bringing clinical management and patient-centered care to the forefront, which is critical.
And that transitions us perfectly into our second poll question for today, which is, what strategies do you think make the most sense to help control and ensure the appropriate use of GLP-1s? I'll give it a few seconds here for the group to put in their responses. All right. All right, as you wrap up your responses here, as you can imagine, right, strategies around controlling GLP-1 utilization and spend, it really does take a multi-pronged approach. And as we take a look here at the responses, I mean, you guys nailed it, all of the above, right? All of these different strategies can come into play, and it can help. I would venture to guess that most plans don't say, oh, I'm just looking at one strategy. It really takes multiple approaches to help really control the utilization and spend of GLP-1. So Sara, can you share a bit about how drug mix plays a role here in predicting what future costs will be for a plan?
Sure, Bonnie. So as it stands today, and I say today because the cost of these drugs, the net cost of these drugs and the different cost models, because as you all know, there are many, are constantly evolving and changing. But as it stands today, at least 25% of your future drug costs will be driven by decisions around whether or not to cover GLP-1s. And if you decide to cover it, how you do so. The detail truly really matters, right? So initial fills. Is your PBM partner allowing you to limit those initial fills to a 30-day supply where members are reevaluated or even evaluated by partners such as Vida and others to see if an increase in dose is reasonable? As we talked about, there are high discontinuation rates, and adherence is an important factor. So again, so many levers to pull to adjust drug mix, including first fill. We talked about utilization management edits in PA, and I saw that on the responses. How does your PBM partner conduct PA review? Is it just a check the box thing and GLP-1s get approved, or are they validating their request? So there's a lot that can be done, and depending on the really menu of offerings and the levers that an employer decides to pick and their partners allowing them that option, that could really dictate 25% of drug costs.
Absolutely. And to your point, right, to help control drug mix and ensure that members are appropriately taking GLP-1s from a clinical perspective and also staying adherent to those GLP-1s, going back to your point, Sara, about the high discontinuation rates, we at Judy Health have a partnership program that I alluded to earlier called RX Activate with Vida Health. And Sara, would you mind kind of describing at a high level what this program is all about?
Sure. Thank you, Bonnie. And thanks to you and your team as well as Vida for really working on this program. So I wanted to make sure to call that out. So Judy Health / Capital RX was actually Vida's first PBM partner. We partnered back with them in 2023. So thank you for that. RX Activate is one of our high-touch clinical programs that offers a comprehensive chronic management in partnership with Vida to really help patients with cardiometabolic conditions and other related factors. So here, think pre-diabetes, diabetes, hypertension. One of the strategies we offer as part of this offering, or really standalone, that we worked closely with the Vida team and their team of clinicians to design, is called an obesity step solution. So this program is really a high-touch approach to and control prescribing for weight loss. So you'd ask, what is the main intervention? What does this program do? It uses a stepwise evidence-based approach to weight loss rather than just immediately defaulting to the use of a GLP-1. This is what Dr. Frank was touching upon, where our goal is not to withhold therapy. It's to make sure that patients have the right tools and those who need it are truly on it and they're getting the most benefit out of it. So patients began with intensive lifestyle, behavioral, and clinical support. Medication use, including GLP-1s, occur when clinically appropriate, not automatically. And as I mentioned, our goal is to ensure that the right patients get the right drugs to reduce inappropriate use and ensure that members are successful who are on the drug.
Absolutely. Thanks. Thank you, Sara. And as we know, controlling cardiometabolic conditions and reducing weight takes an individualized care approach, right? Not everybody needs the GLP-1 right away. Maybe they don't need it at all. So it's an individual approach, which is why member-centered care teams are so important here. And that is, truthfully, one of the differentiators of Vida, and that's what they offer. So I want to pass it over to Dr. Frank to go over a bit more into Vida's member-centered care team model. So Richard, passing it over to you.
Thank you, Bonnie. So we're completely aligned with the description that Sara just shared with you on the treatment of obesity. Obesity is a very complicated disease. It's in fact a chronic disease, and there really is no cure for obesity. The best that one can hope for is remission. And when treating this disease state, you really need to address not only the pharmacotherapy, but behavior, the environment, and really just the day-to-day self-management that the patient engages in. So we've created a multidisciplinary care team to manage patients who are seeking care for obesity that starts with a physician-directed solution. And so it is the physician who diagnoses the patient, creates a care plan for the patient, and ultimately drives the clinical outcomes that I'll share with you in a bit. The day-to-day interaction occurs between either the patient or a registered dietitian or coach, depending on the clinical pathway, and the experience is curated for the patient, meaning they don't have to seek it out. It is pushed to them, and the RD or coach will bring in other Vida clinicians to serve the patient as necessary. We have our own care navigators who are social workers, and they really perform two functions. They can assist with creating an integrated experience between RX Activate and the client's clinical ecosystem for anything we don't offer, for example, metabolic surgery, and as well evaluate patients for the possibility of occult eating disorders. We have our own licensed clinical therapists who can offer talk therapy to assist with depression and anxiety. Our physicians and our registered dietitians carry advanced training. Our clinicians are oftentimes people of color, and we have an entire experience co-located in Spanish. But most importantly for many employers is how we integrate with their core network, their primary care physicians. And we think about that a great deal. Vida does not see itself as a primary care solution. We're really a specialty clinic focused on obesity and cardiometabolic syndrome, and we behave like a bricks and mortar specialty clinic. So when we're prescribing, deprescribing, or addressing side effects, managing abnormal test results, we craft a clinical consult note and ensure that it makes its way to the PCP so we can create an integrated experience. So this is the value of RX Activate with CapRx, is that we've created this multidisciplinary care team. What Bonnie is now sharing with you is really just an example of kind of the patient's experience as they interact in a virtual environment. So naturally, they have to download and create an account, which you see at the far left. And then very importantly, this is not solely a virtual or asynchronous experience. This really involves face-to-face interactions between clinicians and the patients. So here you're seeing a physician meeting the care and the patient meeting the care team, but we also have registered dietitians, coaches, nurse practitioners, and nurses all servicing the patient. And in front of you, as we build the care plan, it's possible for the patient to actually see all of the individuals who are involved in their care, and they can communicate with them in an asynchronous or in a synchronous fashion. As I said, we're not just addressing pharmacotherapy, but we're really addressing the full wraparound program to treat patients. So they receive individual and group coaching. They receive medical nutrition therapy, a registered dietitian-led intervention recognized by CMS. It focuses on setting targets for macronutrients, proteins, fats, and carbohydrates with the intent of creating a caloric deficit. Patients receive a course of self-directed cognitive behavioral therapy to deal with food noise, disordered thinking around food, and emotional eating. And then, of course, we have nurse practitioners and physicians who can prescribe a host of medications appropriate for the treatment of obesity, including the approved GLP-1s. We integrate with a variety of devices in order to help patients track outcomes. It turns out one of the greatest levers for achieving significant weight reduction is simply weighing yourself on a daily basis. We order labs and track those results and manage for outcomes. And ultimately, what we're hoping to achieve here is sustainable change. As I mentioned earlier, what we know is that patients who stop their GLP-1s regain all of their weight and lose all of their cardiovascular risk reduction within 18 to 24 months. So ultimately, what we're achieving here and trying to deliver is not just a prescription for a potent anti-obesity medication, but really a comprehensive obesity treatment program intended to bring down risk and create a sustainable outcome so that employers see the greatest value from this intervention. And what you see here is just a few of our outcomes. We know that roughly 90% of patients who enroll with us are actively using the app. But what's more important than the process metrics is really the clinical and financial outcomes here. For individuals who struggle with poorly managed diabetes, which has significant financial implications for employers, we bring down A1C, a chronic measure of diabetes management, by over 2 points. Weight reduction is significant and exceeds what the American College of Cardiology and the CDC recognize as being clinically significant weight reduction. As patients bring in other comorbidities, we target those as well and improve them. And what this all leads to is incremental savings over and above the types of interventions that Sara shared with you earlier. So this is additive to the kinds of programs that CapRx can offer you from an administrative point of view. And now we bring in the clinical value, which delivers significant financial savings for employers, and importantly, a return on investment.
Thank you so much, Richard. If the audience isn't already excited seeing those amazing metrics and results, I mean, I can say for myself, I'm so thrilled to see both the financial and the clinical side showing positive outcomes. And on that note, what we have done as partners between Judy Health and Vida Health has been to actually take a look and a deeper dive into some of the real-world results that we've been seeing within our own Judy Health population. So here at Judy Health, our clinical team in partnership with Vida did an analysis of our RX Activate data and found some really neat results, as I mentioned, which will actually be presented tomorrow at AMCP annual meeting in Nashville, if anyone's going to be there. Say hi to our pharmacy resident who's going to be presenting on this research poster, Kaylee Mooney. So Sara, let's walk through some of the key findings here, starting from the left to right. So in figure 1A there on the very left, we see that 54% of members were on no type of weight loss medication post-enrollment, which meant essentially that they were doing behavioral change interventions only. Is there anything important here you want to point out?
Yeah, so first of all, this shows that through our integrated approach, formulary aligned approach, and Vida's member-centric care teams, not all members need to go on a GLP-1 right away, if at all. Mm-hmm. So in this subset of 54% of our members, I believe, of our 299, 300-person cohort, we're seeing lots of behavior change interventions. So these are things such as completing consults, messaging Vida providers, tracking metrics, right? When we look at this subset, they average about 39 meaningful activities per month over a 10-month period where they are actively involved. Now, Richard can correct me if I'm wrong, but when you have an engaged patient doing something productive at least once a day, on average, that has to lead to some of these good outcomes.
Absolutely.
Absolutely, Sarah. I think one of the key pieces about weight reduction is that because it's a chronic disease that has significant underpinnings in behavior, simply handing the patient a prescription for Wegovy and Zepbound with a titration plan built into it and saying good luck is not the way to treat obesity. Half of treating obesity really is about adopting new behaviors, and those new behaviors include self-monitoring, typically frequent weight, caloric reduction, activity and exercise, and managing sort of the cravings that go along with hunger. And so while the medications are powerful and deliver meaningful results, as we've said now a few times, in order to create a sustainable outcome, there has to be some behavior change as well.
And Richard, I just want to talk about that just a little bit, because you mentioned something really valuable. When we look at the studies showing really great outcomes for these drugs, right? Those studies looked at these drugs in conjunction with caloric intake decreases as well as behavioral changes, right? So when we were looking for a partner, we were looking for someone to provide comprehensive support, because that is how these drugs are studied. So that is of critical importance. And I think really a great point that often goes missed.
I think you're right, Sarah. In fact, the label itself, the FDA label itself for Wegovy, Zepbound, orforglipron, Foundayo says that it is done as an adjunct to diet and exercise. So the FDA never anticipated that these drugs would be prescribed in isolation without a wraparound behavioral program. And in fact, what we know since the SELECT trial and SURMOUNT trial came out is that there has been additional research published that demonstrates additional weight reduction occurs when these drugs are administered in the setting of a behavioral intervention, as opposed to when these drugs are administered in the absence of a behavioral intervention. So the FDA, the researchers, the pharmacy manufacturers, the pharmaceutical manufacturers, and the literature all support this idea of a wraparound behavioral program. And that was the intent of CapRx when you found us as your new partner 2 years ago.
And I think that feeds nicely into the next figure, which is figure 1B on, I apologize, the prior slide there. Yes, so, because of how integrated the lifestyle change is with someone who is taking a GLP-1, there are instances perhaps when they may not even need that GLP-1 anymore, because the lifestyle piece is helping drive their weight loss. And so in figure 1B, what we saw from our data was that 31 members were on a GLP-1 before enrolling in the program. And then of that 31, 29% of those members discontinued their GLP-1s after starting RX Activate. So what's significant to note here, Sarah, about that?
So I think we spent quite a bit of time talking about how comprehensive management is really critical. And while some patients, like Richard mentioned, absolutely need to be on a GLP-1, maybe others don't, and they could really benefit from opportunities to reassess and possibly deprescribe these agents and optimize the weight loss through behavioral and other interventions, right? So this is something for plan sponsors and employers to consider. 20% discontinuation rate really does factor into savings. And for patients who stay on these drugs, it's also critical to give them the tools to succeed.
Absolutely. And the last thing here to note is, of course, adherence rates, right? We've talked about the importance of adherence. Anyone in healthcare, especially in pharmacy, knows the importance of adherence and taking the right drug at the right time. Here in this figure 3 on the right here, what we saw in the data was there was a 15% difference in the proportion of adherent members pre-enrollment compared to the proportion of members who were adherent post-enrollment. And here adherence, we define it using the industry standard PDC, or proportion of days covered, being greater than or equal to 80%. Sarah, why is addressing adherence important to mention here?
So it's no secret that if you were to just look on a spreadsheet, adherence increases pharmacy spend, right? But I think what we really have to think about is total cost of care, which is critical and we'll soon be able to measure given our unified claims processing platform, Judy. I say that because we regularly see statistically significant uptake and adherence with high-touch clinical programs. One of the programs we see this with is our STARS program for Medicare. So it's really not solely about getting people off of drugs, but it's keeping the right people on the right medications and giving them the tools to be successful. And this is really when employers are able to see total cost reduction, both pharmacy and medical, which is really, really critical when we talk about cost.
Absolutely, absolutely. Now, as we transition to the last two slides here, and Richard, I'm going to pass it over to you in a second. I am so excited to have these last two slides because what we often hear from our clients is, what member testimonials can you share? What's the feedback you're getting about your programs? And what I love, again, about these next two slides here is that these are real member examples. In fact, these are RX Activate members specifically. And these folks have seen significant results through the program. So, Richard, I'm going to pass it over to you if you can give us an overview of these member stories.
Happy to. So these are two real folks, as Bonnie said, Amy and subsequently Adam. Both in their 40s, who joined Vida in 2024. The next slide says 2025, but it's 2024. And Amy was struggling with a number of conditions. She had back pain, depression. Her BMI was above 30, and she had sleep apnea. Our care team, Sherry and Ariane, were managing her, and she entered into the obesity step solution. So she had access to Ariane, who's one of our nurse practitioners. And ultimately, she received a behavioral intervention, as you sort of see below in terms of her engagement. But she also received Zepbound and then subsequently Wegovy as part of her medication regimen and to treat her. So a highly engaged member. She completed 58 lessons, a lot of communication back and forth between Ariane and Sherry. Very importantly, she was very aggressive in self-management. So she logged 425 metrics. And really what that means is she logged daily weights and captured her food intake with our tracker. And we know from the literature that that sort of self-monitoring is a key behavior that correlates with better weight outcomes. And so she was able to lose over 40 pounds. And not surprisingly, as a result of that improvement in her underlying health, her anxiety and depression scores improved. We use the PHQ-8 and the GAD device to assess people for depression and anxiety. And so what that means for the employer is that they invested in Capital RX, they invested in Judy and Vida to help Amy manage her health. And Amy became visibly and objectively healthier and felt better. And what we know is that anxiety and depression correlate with presenteeism, absenteeism, and disability. And as those behavioral indicators improved, we would fully anticipate that Amy became a more productive employee and demonstrated that value to her employer. And as we move into the next slide, Adam's a somewhat similar story. He too has back pain, not surprising. Back pain's very common in our 40s, struggled with diabetes and elevated cholesterol. But Adam actually engaged in primarily a behavioral intervention. So we were supporting him with individual in-group coaching, some medical nutrition therapy delivered by Laura, his registered dietitian, and he would have received some cognitive behavioral therapy support, again, to deal with food noise and emotional eating. That then led him to actively change the way he managed his nutrition and his day-to-day life. So he incorporated more fruits and vegetables into his daily intake. He was more consistent with his diabetes medication, more consistent with his self-monitoring around blood sugar and blood pressure, and he became more consistent with exercise and activity. All of that, not from 2025, but 2024, led to really a significant weight loss. And I think this is very important to double click on. I think while losing weight is incredibly difficult from a behavioral perspective alone, what's absolutely clear from the literature is that roughly 25% of patients engaged in an evidence-based behavioral program can lose about 5% of their body weight, and 15% of individuals can lose close to 10% of their body weight. And in fact, Adam lost about 12% of his body weight through a behavioral intervention alone. Not common, but definitely possible. And actually, it's a much more sustainable weight reduction because it really results from behavior change. So one of the goals of the Vida program, along with Capital RX, is to identify the patients who are interested, motivated, and successful in behavior change and carve them out from the pharmacy experience. That then creates a sustainable outcome with lower cost for the employer. So here we see not only clinically significant weight reduction, really dramatic weight reduction, but also significant improvements in the patient's diabetes outcomes. And this all translates for the employer into a reduction in total cost of care, as Bonnie and Sara have said. So just two success stories to sort of share what it's like from the patient's perspective.
That's incredible, Dr. Frank. Thank you so much. I mean, just looking at this one, A1C from a 7.2 to 5, that's incredible. I know it's the hardest really to get down under that 7 threshold. So that is fantastic. Thank you for highlighting that and the both stories. And with that, before we dive into our final poll question, we do have some great questions in the chat. So after you answer this poll question, we will go ahead and try to get through them live in our last 15 minutes or so that we have together. So we'll give a few seconds here to answer this question, and then we can start rolling through some questions here. And as you do that, if there are questions that come to mind, go ahead and add them into the chat. All right. So we're going to keep the this poll question on for just for a little bit more, but just for the sake of time, we're going to go ahead and start with some questions. So we'll start off with what is the best GLP-1 for A1C reduction and addressing fatty liver?
So Bonnie, maybe I can take that one to start. Sure. My suspicion, although Wegovy has been approved for metabolic dysfunction-associated steatohepatitis, MASH, also called fatty liver, my suspicion is that the dual agonist would be just as effective. So Zepbound would likely be as effective as Wegovy. But Wegovy is the only GLP-1 that carries the indication for treating fatty liver or MASH. And then with respect to A1C, really all of the GLP-1s have dramatic effects on weight and A1C reduction. At this point, I don't recall which is the most potent, but I do suspect it's Zepbound or actually Mounjaro as being the most potent simply because it's a dual agonist. But for patients and employers seeking to identify a formulary and have a GLP-1s, I think any of the GLP-1s would be appropriate for managing diabetes. And I think, Sara, you probably have more insight into formulary design to ensuring that there's really the appropriate GLP-1s on formulary to treat A1C and diabetes. Or perhaps, Bonnie, you'd like to comment.
Dr. Frank, you nailed it. So Zepbound in studies has been more effective. They're actually head-to-head studies, so I feel comfortable saying more effective because, as you know, other studies are non-inferiority studies. We actually at Capital RX have both on our formulary at parity at the same level. So it's really up to the prescriber to pick the agent. What we see is some patients do have more side effects with semaglutide. So the prescriber prefers tirzepatide. So we like to give prescribers the ability to really treat their patients as they deem necessary. I will say because Wegovy is the one that has the FDA approved indication for MASH, that is the one we prefer. We follow an evidence-based formulary, but as you mentioned, there is some research with tirzepatide due to its multi-pronged mechanism of action.
And on that note, that leads to the second question. Speaking of tirzepatide, reviews of Mounjaro. Any additional commentary that you all want to share about Mounjaro from your perspective?
I don't have any unique insights to the reviews of Mounjaro other than it's been in the market for quite a number of years. Mounjaro and Zepbound really are the same formulation, just different indications. Certainly when patients are on these agents, they're quite effective, as Sara just articulated. Typically, you can see roughly 20% weight reduction with tirzepatide as opposed to roughly 15% with semaglutide. To the extent that we're looking at A1Cs, tirzepatide's more semaglutide in A1C reduction. Side effect profile fairly similar. You might see somewhat a lower incidence of side effects with tirzepatide than semaglutide, but I don't know that it's meaningfully different when looking at large populations.
From a utilization perspective, so semaglutide came out first, was added to our formulary first. So of course we saw an uptake of semaglutide. As soon as we added tirzepatide to our formulary, we definitely saw a huge shift. So my suspicion was perhaps some patients were not tolerating semaglutide and their prescriber wanted to try tirzepatide, or as Dr. Frank and I talked about, in these head-to-head studies, tirzepatide seems to be slightly more effective. So that is what we saw from a utilization perspective in data.
Awesome. Thank you, Sara and Richard. We have some questions here. Let's see, about Vida in particular. How many patients, Richard, is each care team member responsible for?
Really depends on the program and the clinician, but it's in the range of 200 to 400. That may sound like a lot, but if you look at the average primary care panel, it's on the order of 2,000 to 2,500. So really we're able to give a level of engagement and attention that it far exceeds what you would find if a patient went to a primary care physician or practice for the care of obesity. Additionally, we have the advantage of content, asynchronous communication, and a multidisciplinary care team. So from the patient's perspective, one of the really value propositions of the Vida program is that you can send a chat or a text to your clinician through the Vida app and receive an answer within 1 to 2 days. And when you think about accessing your primary care physician, typically goes through a medical assistant. It can sometimes take 2 to 3 days. And the ability to have an asynchronous communication doesn't exist, but in our ecosystem, it does.
That's awesome. I was just going to say, from my perspective, from my doc, it takes a while to hear back. So 1 to 2 business days is an incredible turnaround time. That's fantastic. How about this next question here? I think this goes back to you, Richard. How does the care team interact if you have a bariatric team already that has been managing weight loss for that member?
Typically, absolutely. So typically patients after bariatric or metabolic surgery stay with their surgeon for the first 6 months. And we don't advise engaging in pharmacotherapy or really even a behavioral intervention until fully cleared by the surgical team. But at that point, the patient can enroll with us and we can support their metabolic surgery with behavioral interventions to really help them sustain the clinical outcomes they sought from metabolic surgery. Having said that, we do know that over time, some patients who've had metabolic surgery will start to regain weight. and even a small subset may need intervention with pharmacotherapy. And in that environment, as long as we have clearance from the patient's outside clinicians, we can enroll them at Vida and assist them with adjunctive pharmacotherapy and behavioral interventions, either to help them mitigate some of the weight regain, or, as I said, simply achieve some of the maximum value of the surgical intervention.
Oh, excellent. Now, I'm not gonna let you rest. I'm gonna give you one more here, Richard, and then we can kind of move into some of the RX Activate type questions. And you let me know how much or what you can answer on this one. Can Vida access the direct pricing offered by Lilly and Novo?
Yes, we can. So this would likely be outside of the Capital RX relationship, in the sense that the patient might choose to not use their pharmacy benefit in obtaining these agents. In that world, we can write a prescription to the patient, and literally the patient can take it anywhere they'd like. So they certainly can submit the prescription to Novo or Lilly and obtain the direct patient pricing, or we can submit the prescription.
Awesome. Thank you, Richard. I'm going to move to, I think, our last few questions, but if you have more, please feel free to keep them coming in the chat. This one is, I believe, more directed towards our RX Activate program. What percentage of patients treated under your organization's umbrella are female and male? So I guess I'll speak to it from the RX Activate program itself. Richard, if you know offhand kind of your breakdown from Vida in general, feel free to weigh in. From the RX Activate, specifically the study that we talked about earlier, it's about 80% female, 20% male was our breakdown to date.
And I think across our book, it's a bit more heavily weighted female. Sorry, a little less heavily weighted female. So the numbers I'm recalling are in the 60 to 70% range for women to men. Just in general, we know women will pursue weight reduction more frequently than men will. There are also, I think, some demographic and just environmental reasons why they might be with respect to work and time to engage a clinician, but not that much different than what we saw in the abstract.
Awesome. Excellent. And this next one may be another kind of hybrid response here. It's how do you sign up for the program? Where can you find this information for current Judy client members? So I can start off from an RX Activate perspective. If you're a Judy Health client and you are interested, if you're the plan sponsor and you're interested in allowing your members to access the benefit of RX Activate, you can work through our clinical team and or your account management team to sign up for the program, again, from a client perspective. It's a pretty seamless process from a paperwork perspective. We already have our data pipes connected with Vida, so we can send over claims and eligibility data. So all of that is really seamless to get you as the client signed up. Once that has been set up from an implementation standpoint, and now we're at go live, there are a number of ways that Vida, kind of gets the information out there to the membership. In some ways, they lean on the client to distribute and disseminate information via mail or phone or text messaging of sorts. So there's a variety of different ways to outreach there to the member. And once the member sees that and decides they want to participate, that's when they can contact Vida to enroll. So Richard, do you want to kind of take it from there and from a Vida perspective, what that member journey looks like?
Completely aligned with you, Bonnie. Essentially, the member goes to the URL, clicks on it, downloads the app, creates the account. We will know through our data sharing with Capital RX that the client is eligible for the program. And then it's a whirlwind from there. We assess the patient, do a complete past medical history, capture their nutrition history, Depending on the programs the client purchased, the member or patient will be presented a menu of options depending on their clinical indicators, as well as what the client purchased with Judy, and then it becomes seamless from that point on.
Amazing. Love it. The seamless piece, you know, that's the best part, right? We already have those parts connected, and from a member perspective, you know, that onboarding is seamless for sure. So, all right. Well, I think that wraps up the Q&As. If there's, unless I'll give another 30 seconds here if someone wants to input anything else. And if not, I do want to just say thank you on behalf of the panelists here, Richard and Sara, Izadi. Thank you so much for your time, for sharing your expertise. I know I myself learned a lot through the session, and I'm sure the audience has as well. So really appreciate your time with us. Thank you. And thank you to the audience for being here. And with that, I will pass it over to Cooper to close us out.
Thank you so much, Bonnie, and thank you all for attending today's webinar. You may disconnect and have a great rest of your day.